the heart's on the
Oh,
area.
there.
The heart is on
Okay,
the.
so we are
on
not.
Chittenden County.
It's good to take a break.
It is.
You're right.
Yeah.
Yeah.
Trying, like doing that. So we're back live. This is Senate Health and Welfare. And we are continuing testimony on page 766, the prior auth death therapy health insurance claims bill. And Dr. Weigel is here from Blue Cross and Shield.
We're gonna switch.
Oh, how would you like to do it?
Can I have Andrew Gordon go first?
Yeah.
Okay,
Yeah.
we're
So
going
let's
in
do
order of the bill.
That's helpful, thank you.
So now we're on section 2, instead of section 1.
All right. So Andrew is section 2 or section 1?
Section 2, section 1 was step therapy, that was Nancy.
Okay. All right.
I'll talk primarily about claims edits
All right.
and
So
maybe try to talk a little bit about Blue Cross as we go. And I'm gonna read from my notes quite a lot because I know this is really important to you and I want to get this
and we
right.
have it, I think. Do we?
Oh, good. Well, I made some changes last night as I was able to.
Okay,
watch
well,
some
make sure we get an
videos.
update. Direct
Absolutely.
description, that'd be great.
So a quick introduction, my name is Andrew Garland, I'm the Vice President of Client Relations and External Affairs for Blue Cross Blue Shield. I've been in this position for about 10 years, working in this industry since 1998. Most of that time was spent with Blue Cross of Vermont. I've spent a considerable portion of my career working with providers in positions like the Director of Provider Contracting, was the network or the corporate director of network and provider affairs, and for a number of years worked with MVP as the vice president of network strategy and payment reform. As part of that work, I participated in a number of legislative work groups, including the Fair Claims or the Fair Contracting Standards Work Group, 2009, and a previous claims edits work group that was managed by Paul Harrington, in 2010.
Oh, yeah, that's really a long. That's Paul Harrington.
We don't have to dwell on titles, but my primary responsibilities these days are to work with Vermont employers to help them build benefit plans that their businesses can afford. And some of that work, of course, reflects in the QHP as well, where we have individuals, right? We have to design coverage that people can afford. So that's what I do primarily today, although I'm still our healthcare reform lead. So I stay very involved with these topics. I'm here to talk about section 2 of the bill that will have a significant impact on and increased cost for Vermont consumers. But before I do that, I'd like to make an ask of the committee. This is a big ask, and I'm a little bold to do this, but I'm going to do it anyway. Please be deliberate and fully informed about the impact of the changes that folks are asking you to consider making. When it comes to the cost of healthcare, there's no room for error. There's no room for error. Our commercial clients and members bear an outsized portion of the healthcare costs. I think Dr. Weigel is going to show you an exhibit later that will really bring that home. But we pay 3 to 4 times what Medicare pays, and sometimes 5 to 10 times greater than what Medicaid is able to pay. So the commercial market is what allows our healthcare system to continue to move forward. It's the relief valve, the financial relief valve. But that burden is really significant on ratepayers in Vermont. So please just really understand how this will impact them, because as I said, I don't think there's room for error. Now, the changes the bill contemplates would prevent Blue Cross and other payers from applying many of the necessary checks and corrections we do as we process and pay claims. And I just want to emphasize that claims edits, this process, it's a basic financial control. Right? That's the way to think of this process. It's a financial control. And I'm going to really draw that out for you. I don't want that to be an unsupported conclusion. Briefly, though, let me take a step back. And I think Dr. Lynn, she's gone, but she did a great job of giving you context for this scenario. But let me give you some more numbers. First, I'm going to talk about the CPT codes that you mentioned. There's 11,600 in CPT codes, or slightly north of 11,600 CPT codes. As Dr. Lynn said, these give us sort of a uniform language to pass information back and forth across the medical system. Those CPT codes, I think she also mentioned this, they're developed and maintained by the American Medical Association. So this code set is maintained and developed by physician group, right? Along with these CPT codes, there are 69,000 plus ICD-10 codes. These are the codes that we use to pass diagnosis information back and forth. Those were developed by the federal government and are maintained by CMS. There's another set of codes called HCPCS, which give us procedural groupings. My research shows that there's about 1,000 HCPCS in play right now. So let's step back. The point being, we got about 80,000 codes in play. And because these codes can and usually are built in combination with each other, there are billions, or perhaps I'm not good at this math, this is where I struggle a little bit in my statistics class, billions or perhaps even trillions of permutations of codes that can be built right across the system. Even the largest and most sophisticated healthcare providers can and do make mistakes when faced with this level of complexity. We know that, we have evidence of that, it happens, and it's understandable. Health insurance plans have a financial obligation to our members to review provider claims for accuracy and correct billing for the care provided. Claims edits identify errors, overcharges, and in a few cases, more severe incidences of fraud, waste, and abuse. Both our members and the employers who fund a lot of the care, right, that props up our healthcare system, expect their health plan is going to make sure that the bills we're asking them to pay are correct. That's claims editing. Blue Cross Blue Shield of Vermont processes over 9 million lines of claim code annually from all types of providers. And I think it's important to keep in mind that those providers are not just in Vermont. They are in Massachusetts, in New York, Florida. We get claims from across the country and claims even internationally, right, that come to us from overseas. We would be irresponsible and fail to meet a basic obligation to our customers and frankly to our healthcare system if we did not review those billed claims. No legitimate business, no household, dare I say, no New Englander, would ever simply pay every bill that comes through the door without reviewing that bill to ensure that it's an accurate representation of the agreed upon transaction. Claims edits are a widely used method to review claims to ensure accuracy and consistency in coding. And these are not Blue Cross's standards. I really want to emphasize that point. Coding standards are established by external bodies like the American Medical Association, the Center for Medicare and Medicaid Services, and specialty medical societies, the same societies that provide board certification for our specialists, such as the American Society of Anesthesiologists. Blue Cross does not make these edits up. We don't determine coding and billing standards or adopt edits that are unique or ours. Blue Cross relies on the guidance set by these organizations, which are all either governmental or provider in origin, right? They're not our rules. Now, claims edits are only applied to a very small percentage of claims, but they do save millions of dollars by identifying errors in the more than $1.3 billion of claims that Blue Cross pays annually for our members and customers, just in Vermont, over $1.3 billion in claims. Can you imagine a system where an organization moved $1 billion+ in and out without basic financial controls? Those kind of systems lead to fraud and corruption. Basic financial controls are a part of every business core fiduciary responsibility. So let me give you some examples of how a claims edit works. And I'm going to start with a silly one to really illustrate the concept, and then I'll go into some specific medical examples. So let's imagine you go to a restaurant and you order a prix fixe meal, right? Comes with an appetizer, a salad, an entree, and a dessert, and the whole mass is $75. Okay. The bill comes to you, and you look at the bill. $75 is there, but there's also a $12 charge for that salad and $14 charge for your dessert. What are you going to do with that bill? You're going to raise your hand, call over that server, and send it back. It's an overcharge. those prices were supposed to be built into the prefix price that you agreed to when you ordered that service, right? That's an example of a claims edit. A claims edit is looking at the services that come across and making sure that they're being billed appropriately. And again, according to guidelines developed by CMS and provider associations like the AMA. So now I'll give you some medical examples because I think we need to go deeper than salad, right? These are some of the easiest examples I can find. They're a little obscure, but hopefully they'll be relatable. So we have an edit, and this is actually an edit that I think could potentially be eliminated by the proposed language if we don't make a change, for multiple code rebundling. What that means, very similar to the dinner example. It identifies a claim that contains 2 or more procedure codes used to report a single service when a more comprehensive procedure code is available. So in other words, there's a procedure code that encompasses both of those services and anticipates them being performed together and sets the reimbursement appropriately for the amount of work that's required to do those 2 services at the same time. But if those 2 services are billed independently, right, that if they happened independently, that would be more work for the provider because they would have to do all the work over here, tear it down, come over here and do it again. But when those things happen at the same time, it's less work for the provider because the setup, the wrap, all of that work only has to be performed once, and the code set developed by the AMA and the edit anticipate that and says, okay, you mistakenly billed us for 2 separate procedures, but there's a code that contains them both, and since you perform them both at the same time, that's the appropriate billing. So a claim edit would look at that situation, put those 2 codes together, use the comprehensive code and send the reimbursement back to the provider. I also want to note there's something very positive in that for the provider because the alternative would be for us to deny that claim as inappropriately billed. Because it is inappropriately billed if it comes to us that way. And if we deny it, it gets sent back to the provider and they have to go do the research themselves and recode the claim. So there's administrative burden in every situation, right? And it's not clear from the examples that we're going to look at today or from the larger picture that just removing some of these claims edit really relieves administrative burden because it certainly will lead to more denials and more claims resubmissions. A second example, okay, this one is a little, they're going to get more obtuse as we go, but, or not obtuse, that's not obscure. Procedures and services received with a secondary diagnosis code as the principal or primary diagnosis code. So CMS in the ICD-10 code says, hey, some diagnoses cannot be primary. They're secondary diagnoses. They can only exist if there's some other diagnosis above them. And we really have to be careful about how we pay claims that are related to that diagnosis code. You can't pay on that secondary code until we're sure what the primary code is. So when a secondary code is billed as primary, a claims edit, particularly if the primary code is in there, we'll fix that, write that claim and send out the appropriate reimbursement. Again, avoiding a denial. The final example I want to give you is an example of a billing practice that has necessitated.
I think you have a question here.
Yeah.
I just want to make sure I'm clear about what happens, a denial versus a claim edit in terms of the administrative process and the timeline. So if you get one of these that you are not able to edit and you just deny it, what happens then? You send it back to the provider. What do they have to do?
Well, some of our provider partners might be able to talk more about that, but I think they have billing units that then investigate those denials, right? They open up the claim and say, why was this denied? They go into the records, they find the mistake, if there is a mistake, or they determine, okay, this is a legitimate denial. It's not a covered service. We're not allowed to bill this because we don't have a license to provide this kind of service. Different reasons that claims could be denied. But usually, if the provider thinks that we've made a mistake in denying the claim, they'll just recode and resend it.
And resend it back to you. So they'll do some kind of investigation and send it back. So on a claim edit, again, you would do a claim edit to something they did saying, we don't think you've billed this correctly, we're gonna correct it. You then send it back to the provider, right?
That's right. With reimbursement, goes with the money. Yeah.
Oh, so the money goes with the claim.
Yeah.
So you'll say, you billed for these things, you billed this incorrectly, we're editing it, but we're sending you the money for how we've edited it.
That's correct.
And then what does the provider then do? They can either accept the correction and the payment, or they can say, no, I think we were correct and sort of
Yeah.
do an appeal kind of thing?
That's right. Yeah, we are always willing to talk to our providers about what's going on with the care that we're funding, always. So yeah, that's exactly right. They would just reach out to us and say, we think you made a mistake here. And we will look at the record and make a change if that's appropriate. And I will say, we're going to talk specifically about the 2955 modifier challenge that frankly, we created. I'm going to own that. Outside of that process, claims editing goes very smoothly, and we have very few complaints about this process historically. And very few trouble spots, very few appeals. Generally speaking, claims edit works to do what it's intended to do, get the billing correct.
But then you created a problem with the 2559 situation.
And I'm going to talk about that in just a moment.
And, okay.
A good faith problem, I might add. Or
Okay. So
the result
I
of a good
think
faith.
probably we need
Yeah, I'll move it
to,
up.
let's just move
Okay.
it along, because.
So let me give an example of the sort of billing practice that has necessitated edits. When I started in provider contracting, hospitals and out-of-state surgery centers would routinely expect to be paid 2 or even 3 times for the same colonoscopy. I know that is hard to believe, but it is true. The provider would perform a diagnostic colonoscopy and in the course of the procedure, discover or remove a polyp, and later discover and remove a lesion. This encounter would then be billed to Blue Cross Blue Shield as 3 colonoscopies: a diagnostic colonoscopy, a colonoscopy with polyp removal, and a colonoscopy with removal of lesion. The second and third colonoscopies would come with that modifier 55 to tell us that these are separate and distinct procedures. You probably think I'm exaggerating here, but I'm not. I sat across the table from hospital administrators who yelled at me for not wanting to pay 3 times for the same procedure. Additional payment for the polyp removal? Absolutely. Additional payment for the lesion removal? Absolutely. But 3 separate colonoscopy reimbursements, $4,500 of reimbursement for a $1,500 procedure? That's not right. So these edits exist to correct mistakes like that, and those mistakes often come from genuine and understandable misunderstanding by providers. This is a lot of complexity. So now I'm going to turn to the bill. There are 3 pieces of the claims edit section of the bill, and I want to keep them separate during the discussion. The first 2 I think are going to be pretty easy. The first, I'm going to actually take these out of order. So the order of the bill is first the overall rules that a health plan must follow for which claims edits we might implement, right? The second is the process for adopting new claims edits, and then the third section is specific to the prepayment coding. This is when we ask for medical coding or medical determination before we'll pay a claim. Most claims edits don't require that kind of documentation. This is the modifier 2955, 2559, no.
2559.
This is the modifier 2559 problem you've been hearing about today. This started on January 1, 2023, and I know you've all heard from a lot of providers in the communities about this topic. So I'm going to start with that one last. We implemented these change edits, these claims edit changes in January. The big one was the modifier 25 and 59, I'm getting myself confused, to prepay. We moved that from prepayment instead of post-payment, right? Sometimes we would audit those anyway, but we try to collect those medical records after the service happened, after the bill was paid, because we were concerned that maybe there was a problem with that bill. Post-payment audit has its challenges too, because all the money has already moved. Providers have been paid, members have been billed and paid their deductibles or their co-pays. So post-payment audit comes with a lot of problems. We're trying to solve some of those problems. We underestimated the impact that this change would have on some providers. And we were unprepared, truthfully, to handle the number of questions and issues that arose from the changes that we made. And for this, I want to apologize to the healthcare community and to you all, because you had to wade through this. We're committed to doing better in the future. So 8766 addresses this issue specifically on page 6, sections E1 and 2, where prepayment coding validation will be prohibited beginning on January 1, 2025, except in some very certain narrow circumstances. So,
Sorry.
yeah,
Repeat that, please.
page 6, E1 and 2, I think is where we've got that language. I know you're receiving letters from providers. We're working with them individually to solve this problem, and we are winding down the application of these prepayment reviews in anticipation of the change you're going to make. So we're going to stop these programs before you do. Essentially, that's where we're going. We understand that we created a problem. So next I want to talk about the language for adopting new claims edit. Current law requires us to submit our coding changes to DFR in advance of implementation and then give appropriate notice to providers before the implementation, among other requirements. This bill would allow claim edit changes quarterly going forward and lays out a process for keeping current the CMS coding changes. This is on page 5 at the bottom. I think this is section D, and we're going into page 6. This is a little restrictive. It's very restrictive, but it's work. If this is important, we can make this work. The final topic, and this is where I want to push back a little bit, the changes made in the overall application of coding edits, this is where we have the most challenge. So page 4, section B1, restricts outpatient and professional claim edits only to NCCI edits that are used by Medicare. It restricts facility claim edits to only the Medicare code editor used by Medicare. It excludes pharmacy claims edits entirely, and it allows DFR to approve nationally recognized standards, guidelines, or conventions for any claim that is not covered by those 3 previous circumstances. These severe restrictions on our ability to apply claims edit, except for those used by Medicare, is very problematic. Commercial health plans pay far more for the same services than Medicare and way more than Medicaid. Inappropriate coding has a much bigger impact on commercial members and the businesses and nonprofit organizations that pay for a lot of their premiums than they do Medicare and Medicaid. Their reimbursement is so much lower. These editing practices are not as critical to them as they are to us. Blue Cross Blue Shield of Vermont covers a wide range of services, outpatient, professional, facility claims that Medicare simply does not cover. Leaving those services without any appropriate claims edits if we don't bring in the other standards that the AMA makes available to us. And I'm going to give you some examples of things that we pay for that Medicare does not. Naturopaths, licensed alcohol and drug counselors, psychologists, board certified behavioral analysts, certified midwives, acupuncturists, athletic trainers, hearing instrument specialists or hearing aid dispensers, licensed genetic counselors, international board certified lactation consultants, licensed professional counselors, pharmacists performing medication therapy management outside of a retail pharmacy setting. That's a short list of the provider types. There's more. Health plans pay for thousands of services and procedures, equipment that is simply not covered by Medicare, and I think generally not covered by Medicaid either. Our members pay for the waste, either through their premiums or through their cost share. 40% of our members have a high deductible health plan. So when a code is inappropriately billed, when that dessert is billed separately, a member pays for that, either directly through their deductible or indirectly through their.
So I'm gonna say you've been talking now for 25 minutes. And I think that if you have this in writing
I do.
and your critique of the bill, it would be helpful for us, I think, to be able to do it as we review the bill section by section. So it is very helpful to hear you present, but our time is such that, and we may ask you back to answer questions.
But I have 2 or 3 minutes to make my ask. I'll jump over the rest of the detail, but I really want to land on what I'm asking you for today.
Okay. That's
Please
the
slow
question.
down a little bit. If you're really trying to make an impact, you're trying to make a statement, please just.
Sure.
Thank
Okay.
you. Did you have questions that are already?
No, you're getting mixed messages about going fast or going slow, so sorry about that. So I think.
I understand you have a tremendous amount of ground coverage. So here's the ask. Either allow nationally recognized standards, guidelines, and conventions for all types of claims, or at least add pharmacy claims in, or any other claim type that's not covered by Medicare. We have to have financial controls for all the claims, and the Medicare rules simply don't give us that. Please don't restrict DFR from approving claims edit if they see fit for those categories that we talked about. And please remove the underlined language for any other claim not addressed by subdivision A, B, or C. This will all be in the written testimony. Finally, a large number of claims edit being rolled back by this section. Blue Cross has been applying successfully with few or no complaints for years. This is where we account for a great deal of the estimated cost of this bill. Consider grandfathering those existing claims edits. We're gonna pull back that prepayment audit. You're gonna mandate that. Let's pull back on the language that takes away those very good claim edits. And then the final ask, please protect ratepayers from the cost of these changes. We understand that providers need to get out from the administrative burden. Frankly, we do too. We support that priority. We don't want our providers being weighed down with administrivia. So as you work to ease that burden, can you please include language that insists that the costs that are created by the reduction of the administrative burden be offset by reductions in the cost of care that are at least equal to the cost of removing these programs. So what I'm saying is, if healthcare costs more because of easing the administrative burden, don't let it. Insist that we have to find somewhere else in the cost, in the healthcare system to eliminate those costs. Our members simply cannot bear anymore. The cost of healthcare increases so much faster than their income, than the revenues generated by their businesses. We know that this gap exists. They cannot keep up. They can't keep up. And this is why I say that the mistakes that Blue Cross has made here were made in good faith. There is not enough money in the system to pay for the care that we need. There is not enough money. So we have to turn over every, whatever you turn over, carpet, cushion, I don't know, looking for opportunities to eliminate wasteful spending. I'll stop.
Thank you. And your testimony is important to us, so, and having your edits of the legislation
Yes.
line is helpful. Appreciate it. So we're going to move right on
Thanks.
to Dr. Weigel. Thank you for being here.
Thank you. Sure. Thank you for having me. Hopefully speak efficiently.
Not too fast, but not too slow.
Right.
Get the Goldilocks.
This is the Goldilocks.
Oh,
zone.
too slow is
Exactly.
fine. Too fast is right.
So I'm moving on to prior authorizations. Prior authorizations are a way to approve treatment based on medical necessity. Prior authorizations protect patients and manage unnecessary costs in the healthcare system. We are navigating the space between healthcare costs that are unsustainable for Vermonters and hospitals that don't want limits on cost and utilization. I understand prior authorization is unpopular amongst providers, but a targeted, sensible approach is essential to keep costs down. Similar to claims edits, medical policies for prior authorizations are based on a variety of sources, like clinical evidence guidelines established by medical literature and organizations like the American Medical Association, specialty organizations like the American College of Cardiology. That's what our medical policies are based on. Most prior authorizations are done electronically, and if they satisfy criteria, they're automatically approved. This area is rapidly developing with new technologies to ease provider burden. More to come on that hoping too. I want to give you a couple of real examples of how Blue Cross's prior authorization program works and results in improved outcomes for Vermonters. And also why it's not responsible and unprecedented to require Blue Cross Vermont to cede every prior authorization decision to Vermont Medicaid, as would be required by this bill. It's important to remember that a prior authorization does not always equate to finding a lower cost alternative treatment. Based on the circumstances, we may recommend using a more expensive option first. This eliminates unnecessary or potentially harmful steps. An example from last week, there was a 39-year-old member with knee pain and a suspected meniscal injury. Her provider requested a CT scan instead of an MRI of the knee. Although an MRI is the optimal test to evaluate the soft tissue of the knee, providers sometimes request a CT scan as a cheaper, faster study, without realizing that it's diagnostically inferior for many indications. Without our advanced imaging prior authorization, the member would have undergone the CT scan and unnecessary radiation that would have yielded little useful information. And they would have had to have ultimately had an MRI of that knee to see what was going on. Some tests are not supported in certain circumstances. For example, last month we had a 56-year-old member with chest pain, but it was not chest pain that's typical for cardiac issues. And the member did not have any cardiac risk factors like obesity, high blood pressure, diabetes. The doctor requested a heart perfusion study to evaluate blood flow in the heart. However, the member did not meet our criteria for that study. During the physician-to-physician peer review, we explained the rationale for not performing the study for this member because of the very low likelihood of actually finding disease and the risk of false positive studies. I think after COVID, we know what false positives and false negatives are, but in medicine, getting there. False positive tests carry their own risks. They can lead to unnecessary medical interventions, treatments, or procedures. They can expose individuals to the risks associated with those interventions and adverse reactions and psychological distress. Finally, they incur additional costs for follow-up tests and treatments that burden both the individual and healthcare system. We do not ask for prior authorizations for emergency care, x-rays, preventative care like tests around diabetes, blood pressure, mammography, colonoscopy, well visits, prenatal care, immunizations. In fact, most healthcare services are excluded from prior authorizations. The national prior authorization denial rate is 17%. That means of the requests that come in, if 100 requests come in, 17 get denied. Whereas our prior authorization denial rate at Blue Cross is low at 7.7%. While we may seem low, and we've heard providers say that this means we're wasting their time, it's actually not true. First, 7.7% is the average denial rate. The approval rates for some providers are much less, which is why the denial rates are much less for some providers, which is why we implemented a gold carding program to allow those providers who are consistently approved to not have to do the prior authorizations. Second, as Andrew noted,
That was done legislatively. I just want to share with you, it wasn't we, it was us.
As Andrew noted, Blue Cross pays over 1.3 billion in healthcare claims, so not authorizing 7.7% of items we prior auth is a significant savings and serves to reduce premiums for members. In fact, our estimates show that our prior authorization programs, net of the cost to actually operate them, saves our members 3% of their premiums. And just to take a step back on the totality of H766, the changes to claimed edits, step therapy, and prior authorizations will impact our exchange population, our QHP population, with $25 to $30 million in increased costs. This amounts to a total impact of H766 of 5 to 7% of member premiums. This will be a 5 to 7% increase over what already is in store.
Question, I'm
Yes.
going to go back to another question we had earlier, which is how you derive that number and what analysis you used to do that. And did you also present it in the House? I don't know. You did, okay. So if we could have the evaluation that you did,
Yes.
actuarial analysis, whatever you have done, that would be helpful.
Yeah.
Okay.
My question too.
Good, yeah, I know what it is.
Sure. So for example, if our rates were to go up 5% next year for 2025, if H766 passes its entirety, it will go up by 10 to 12%, so a double-digit increase.
And I have another question for you while we're here, and I don't know who answers it, maybe it's you, Sarah, but when we talk about prior authorization and the concern about overutilization, we also have looked in the past at fee for service and overutilization, and right now, does Blue Cross and Blue Shield utilize value-based payments to reduce the fee for service problem So how do you fit that into all of this mix? This is not a question you can answer off the top of your head, but it's critically important. What are we holding constant when we're doing these analysis?
We'll get back to you.
Good?
I can answer off the top of my head, but I won't do.
No, that's good.
So for example, this bill alone would increase employee insurance costs for small businesses by about $1,000 per year. When I spoke with Derek Martins, who owns Brothers Building in Waitsfield this morning, he was shocked about the possibility of a $1,000 per employee cost per year from this bill. Areas of support were supportive of the change in urgent turnaround times to 24 hours. That there is a provision to delay this until 2026, which we will need to update our technology, so we appreciate that. There's two service areas of concern with the urgent requests. Again, emergency treatment is always covered as if being required. But one is around out-of-network providers. These are providers who are out of state or who do not contract with any Blue plan in the country. So in addition to reviewing prior authorization, we also need to negotiate an individual case rate for those providers. So we'd like to exclude out-of-network providers from this turnaround time. Also, durable medical equipment. These are things like catheters, machines to treat sleep apnea, wheelchairs. DME is where we see the greatest amount of fraud, and it's usually not providers, it's usually DME retailers. You can Google some of the phantom billing that has occurred for Medicare, resulting in $2.8 billion in charges for catheters. And for example, this past year, we received a request for a wheelchair that was $150,000. If you Google most expensive wheelchair, I don't think you'll find one close to that price, but this is a reason we need a little extra time to be on top of the DME. The other provision that's probably most concerning is the request to have us match our prior authorization list with that of Medicaid, Vermont Medicaid. There's significant differences between private health plan coverage and Vermont Medicaid. Medicaid coverage does not extend outside of the state of Vermont. It's focused only on Vermont-based providers, whereas Blue Cross has extensive national and even international network of providers. Our members often seek services and treatment out of state, and we need to make sure they're getting the best and most appropriate care. Also, Medicaid is a government payer that operates under different federal and state laws. It has no premium requirements and very low out-of-pocket costs. In contrast, our out-of-pocket costs for members on commercial plans can be quite high on the high deductible plans. Commercial plans also have unique covered benefits, as was mentioned, the GLP-1 weight loss medicines, which are upwards of $1,000 a year, and CAR T therapies, which Medicaid does not cover, which cost between $500,000 and $1 million. We need to make sure these treatments are used only when necessary. When I was talking with Dr. Rappaport at DEVA, we were talking about these prior authorizations, and he said, you know, Medicaid pays a fixed rate for items. It doesn't flex that rate when high levels of customization are necessary. He gave the example of a prosthetic leg, for example. If it's very basic, you know, might be $800, but if it's very high tech, it might be $70,000. Vermont Medicaid pays one price for that prosthetic, whether it's basic or high-end, customized. I think in the handouts the handout that you have, you can see some of the cost comparisons there for around savings on advanced imaging in particular. I know there was discussion around Medicaid removing advanced imaging prior authorizations. Vermont Medicaid's total yearly spend on all imaging, including standard x-rays, is $5.4 million. Blue Cross's yearly spend just on advanced imaging is $56.5 million. And our prior authorization savings alone are more than Medicare's entire spend on imaging at $6.1 million. Also, you can see in the handout that Vermont pays a significantly higher price than Vermont Medicaid. For an MRI of the brainstem, they pay less than $300, and we pay more than $4,000. With sleep studies, they pay less than $800. We pay more than $6,000. And for varicose vein treatment, they pay less than $2,500, and we pay more than $19,000. As you can see, Vermont Medicaid has a much lower financial incentive to prior auth these items. If we paid Medicaid rates, it would be a much different discussion. But we do take a judicious approach to how we address prior authorizations and financial burdens to our member. For example, with advanced imaging, we recently removed the prior authorizations for all imaging done at a facility called Open MRI. They have sites in South Burlington and Lebanon, New Hampshire. This enables providers to refer members to Open MRI without obtaining a PA for advanced imaging. This is a facility that has lower cost, high quality imaging. We'd like to redirect care to that facility. And that's an example of increasing value. We removed the PA for advanced imaging for in-network providers who had a low denial rate, and we also removed the PA for advanced imaging studies at UVM Health Network that had a low denial rate. This past year, in 2023, in the beginning, we removed mental health substance use prior authorizations for all in-state, in-network treatment programs, inpatient, residential, partial hospital, and IOP programs. As a psychiatrist, I'm particularly proud of these prior authorization removals as they increase members' access to critical services on mental health. The provision to match Medicaid is really unworkable, especially from the timeline. If the comparable example is really like if the federal government said that all the New England states had to have similar statutes or the same statutes, and Vermont, New Hampshire, and Maine needed to switch to the Massachusetts statutes by January 1st, it would be a huge undertaking. And that's really what we're talking about with Blue Cross moving to DIVA's prior authorizations.
So I'm gonna ask you to wrap so that we can get to MVP because we have another person after.
You bet. So there's another table. There's not about the crosswalk between RPAs and Blue Cross, which I'll give you notes on and you have for your review, but it's not really a one-to-one. And given DIVA's current focus on unwinding Medicaid for some members and other projects, they would certainly need a lot of resources to make this happen. In short, despite its unpopularity among providers, prior authorization processes are grounded in clinical evidence guidelines that serve to optimize patient outcomes while minimizing expenses. Stop there.
That's very helpful, and if we can get that
You bet.
on our webpage, and your complete testimony would be very useful.
Yes.
This is good. Thank you. So we want to give attention to MVP as well as Blue Cross. And Jordan Esty is here in Albany. He was going to drive up here, but the weather didn't look great for that. So Jordan, thank you for being here.
Yeah, thank you, Chair Lyons and members of the committee. Can you hear me all right? Can you see me all right?
Yes, yeah,
Great.
it's fine.
Great. So for the record, Jordan Esty, I'm Senior Director of Government Affairs with MVP, and my colleague, Dr. Claire Bolin, is here as well. I'm going to talk about the bill, and given the time constraints, I certainly won't dwell on a lot of the points that my peers at Blue Cross Blue Shield made. Andrew in particular, I think, did a really good job articulating some of the challenges with the claims edit sections of the bill. And Dr. Bolin is a medical director at MVP, and she can provide some commentary because she has a unique perspective as somebody that was a practicing pediatrician there in Vermont for a long time and now works as a medical director at MVP. So she's seen the issue from both sides. So she has a valuable perspective should the committee have questions that she can help answer. So just at the outset, for the record, I want to be clear that there are certain sections of the bill that MVP supports or is comfortable with, just like Blue Cross Blue Shield. In the House, there were a lot of productive discussions with other stakeholders that really improved the bill, where we were able to find pro-patient and pro-consumer areas of common ground. So, ensuring that prior authorization requests, in particular urgent prior authorization requests, are reviewed and decisions are made within a 24 or 48-hour timeframe, MVP can absolutely support. From our view, it's about ensuring that patients are getting, the care that they need, in the fastest time possible. delaying access to care benefits no one. It's not something we want to see happen. So we're supportive of that. Step therapy, kind of same concept. You're looking to structurally set up a process by which a provider and a patient can seek exceptions to these rules, again, to ensure access to drugs that are appropriate and necessary. We support that because we largely comply with that in New York today. And again, that is, pro-consumer. We do share the concern that Nancy Hogue raised about the 5-year period on pharmaceutical prescription drugs. But my comments, going forward are really going to focus on the areas we have the most concerns. And those are also sections 2B regarding clinical edits, and then section 3, which would require the commercial alignment with Medicaid prior auth standards. So again, Angie, I thought did a really good job of stepping through claims editing, why we use it, why it's important, how it's an important financial control. And, we share all of the same kind of recommendations about, the challenges we would have with 2B in particular, and some suggestions on ways to improve this and make it workable going forward in a balanced way. Section 3 regarding Medicaid alignment. Again, I would ask that we really keep in mind the impact to consumers, the impact to Vermonters. So we understand the burden and the burnout that our providers are experiencing. We're committed to enhancing the provider experience to the member experience. That's something that as a company we take very seriously and is always kind of the North Star. As it relates to prior authorization, we've actually went and reduced the number of items we require authorization on over the last 6 or 7 years by about 50%. And it's all with the provider experience in mind. If we're asking providers to submit paperwork and spend time on administrative tasks that are not providing real value for our members, and it's causing unnecessary burden for our providers, we don't want to do it. We're looking to remove it. As a general rule, we don't add a prior authorization unless, we're certain that it's going to yield at least $5 in savings for every dollar that we have to spend on administering a prior auth program, right? So there's very real ROI in the prior auth services that we look to, the prior auth programs that we look to implement. And I want to make sure that this is reflected as well, that prior authorization costs MVP money as well, right? We have to hire staff to do the reviews, to have the peer-to-peer consults, to continually assess, new treatments, what the national clinical communities are saying about the efficacy and the safety of a treatment. So there's a cost to us as well that we're very, very mindful of. So it's very important that we try to strike a balance. And philosophically, that's what MVP's, committed to doing. Before I get into, specific concerns about cost and some other, observations about the complexities of complying with Section 3 in particular, I just want to highlight a few important points for context. So the scope of this bill's impact will be limited, and it's not going to affect most commercial insurers or members that are with most of those insurers. So, there's a lot of, stories and examples that are shared about the experience of a patient that has had a prior auth decision delayed, and that has resulted in, adverse effects to their care. That's something we do not want, and I think it's, for the most part, we're looking at something like that example. We're turning around a decision in 24 or 48 hours. So, some of these examples that are being conveyed, it's very likely the case that it may not be one of the payers that are serving the markets that this bill will affect. So reducing administrative burden is an important goal. It's one that we share. We need to appreciate that despite good intentions. Some of these changes, I think, will have unintended consequences and may not provide meaningful improvement for our provider partners at the end of the day. So we want to be very mindful that, especially given the cost concerns that Andrew, again, really, really focused on and articulated well. At the end of the day, if we implement something that's not workable, that increased costs and is not providing any value in return to consumers, either by expanded access, better health outcomes, that's something we really need to be mindful of and careful about. So patient and consumer costs associated with Section 3. So we did a pricing estimate on just these two sections, 2B and 3. So it's relatively conservative compared to where the Blue Cross Blue Shield assessment was. We did not provide a cost estimate in the House. because this was kind of fluid and, limited resources as a smaller plan. We did have the opportunity to take a few weeks and try to put together a cost estimate, and you should have this as a handout that was circulated. But we are estimating that these two sections will cost our 27,000 members about $9 million in 2025, which is about a 3% increase to premium. Again, that's probably on the conservative side because there's thousands of codes and Medicaid criteria that we just haven't had the chance to do that deep of an analysis. Same thing on the clinical edit side. But premiums, so that's 3% to premium, not insignificant, especially for markets that are really struggling with the cost of healthcare. But out-of-pocket costs, I really want to emphasize as well. So most of our members in Vermont, our commercial members, have some form of a deductible. Most of those with a deductible have a high deductible. So we're talking about deductibles in the thousands of dollars. Their premium's going to be thousands of dollars as well. So why it's important for out-of-pocket costs is they pay 100% of the price of a service until they meet the deductible, with certain exceptions. And then after they meet the deductible, they're responsible for a percentage of that underlying service cost. So in the handout we have shared, we tried to put together a couple of examples as it relates to what Medicaid pays, what commercial pays, alternatives that are available now that may be less costly, but just as clinically effective in a certain situation, and what the net out-of-pocket cost would be to a commercial member in that scenario. So one of the examples was an MRI head scan, which cost MVP about $1,700. It cost Medicaid about $240. A CT head scan, which may be clinically appropriate in certain circumstances, is about $700. So that could be preferred under a prior authorization approach in a number of settings. At the end of the day, we would not be able to prior auth that particular MRI because Medicaid doesn't prior auth it. So that leaves the consumer paying a net increase of $1,000 more for the service should this become law. I would, on cost, I really want to emphasize the importance here. We need to ensure our members get the highest quality of care while also managing overall costs. The notion that costs are a red herring or not a significant concern, I think, is misguided. This is not MVP's money. It's not the provider's money. It's not the legislature's money. And we need to really take these changes into account, understand, how they're going to challenge members that are already struggling with the cost of healthcare, and for markets that are struggling as well. In terms of compliance costs. So the cost to MVP to comply with Section 3 would be substantial. We have about 500,000 members across upstate New York and Vermont. Our Vermont presence in commercial markets is about 27,000 members. So we would have to build today, generally kind of our rules for both claims edits and prior auth don't vary too much by geography, right? It's generally the same. So we would have to build a whole new kind of IT system configuration. We would have to go through and rewrite a number of medical policies and the edits associated with those. We'd have to hire staff, to support additional reviews and, working with DVA to stay on top of the changes that Medicaid is making. So there's a very extensive cost associated to MVP for what amounts to a very small percentage of our total membership. Now, I think it was Dr. Weigel that talked about Blue Cross having members that are in Vermont that seek services out of state. Same situation for MVP, but we also have thousands of members in New York that see providers in Vermont. So this bill, these changes in the bill would not apply to our New York members, and we would not be applying them to those members. So if you're in a provider's situation, you're now going to have MVP members, and the set of rules that would apply for that member's coverage are going to vary depending on where their policy is issued. So in many respects, we think this is going to increase complexity for members. And again, at the end of the day, if it's increasing costs and it's not materially reducing the administrative burden, then what have we solved?
So Jordan, I'm going to ask if we could move on to medical director, because we are really, we've got about 10 minutes left for MVP, and then we're going to move along.
Sure. I just want to make 2 points on the market and really taking a step back. I mean, what we're talking about here is changes that will affect largely the state regulated insurance markets, so the exchange markets. It's a small percentage of Vermont's kind of total insured population. in terms of where Vermonters get their health care. And really important, this is in the handout we circulated, the number of employers that are leaving state-regulated markets to find more flexible and affordable options, over the last decade plus is significant. You can very clearly see that trend. So
we hear that and we understand what you're saying. We also know that our providers are leaving the state, and apparently Dr. Boland is one of them. So
right. Well, thank you for your time. I'm going to turn it over to Dr. Boland and happy to answer any questions.
yes, thank you. Good. Dr. Boland, welcome.
Hi, thank you, Jordan, and thank you, Senator Lyons and the committee members for allowing me to testify today. Bear with me a little bit. I'm nervous because I've never done this before. So
You're fine. You'll be fine.
Thank you. So yes, what Jordan said is true. I'm a board certified pediatrician. I've worked more than 30 years in the Division of Pediatrics, and 20 of those have actually been in Woodsville, New Hampshire, Bradford, Vermont, or Newbury, Vermont area. So that's a very rural section of our state, right on the border of the Connecticut River in New Hampshire, where I worked for an FQHC for a period of time, and then in a private practice, a small rural private practice. Then in 5 years ago, I took on the position of medical director at MVP and have been working with them since then. So there's a couple of points that I wanted to make, and one of those is that, yes, I'm very much aware of the administrative burden of the requirements that the insurance companies will often have for things such as prior authorizations. And ran into those when I was in practice for sure. I think pediatricians have a little bit of a better or less of a burden than possibly our adult components, because a lot of the new services, new testing, new technology is all really focused more on the adult market. Our kids get preserved a little bit more and don't have that much of a burden. And so I understand that. And I think when I switched over to working with MVP, saw the other side of that, looking at population medicine, looking at the big perspective of what is appropriate in terms of services and what the benefit of prior authorization, or actually the reason that we do it, and the reality is that the things that make treating members good, effective, and giving good care is having evidence-based information to know whether some of these new technologies, new things coming out, are these really standard of care? Are the new things as good as and effective and really make a difference in terms of how our patients benefit for them? So if testing or things like that are being done, and the bottom line is that it doesn't improve the outcomes for our members, what we call low value care, it doesn't improve the patient's well-being in the end, then those are the things that we look at to say, well, are these necessary? Are they medically necessary? And should they, does this particular patient, should this particular member be approved to have these services? And so the prior authorization, though, comes from standard of care. What we look at and what we decide to put in a policy is not just something we take out of the air. These are procedures, these are treatments, these are requests that we're getting from providers for us to be reimbursed for. And we're looking at, it's our chance to say, is this the best cost-effective treatment for this member? Do they qualify based on the policy parameters that we have? But all of that is based on evidence-based medicine. We're looking at what studies were done. We're looking at what other insurers are doing. We look at CMS regulations and Medicaid regulations, and all of that is combined when we decide if we're going to put something on prior authorization or not. But it doesn't stop there. We review these services that we're prior authing definitely on a yearly basis and much more frequently, usually because we have had some conversations with our peer, with a peer-to-peer review or an appeal where we're speaking and talking directly with our providers of services, and they will, can verbally tell us, well, this patient's an exception because yes, your policy says this, but this is why we feel that this is important. And we do make those changes and we will make exceptions. So this isn't, it isn't set in stone. There is medical decision making on it, which is why medical directors exist within the world of managed care. And what we're trying to do is give our members the best, most effective care that they can get, trying to eliminate waste and care that is invaluable. And at the same time, looking at the cost of these services. But the cost is actually the lowest part. We don't look at the cost when we look at policy. We look at what's the effectiveness of it and what is the standard of care. There isn't anything that's considered standard of care in terms of treatment, evaluation, procedure that MVP doesn't reimburse for. It's these technologies or these medications that haven't yet reached the threshold of being in our area, or in whether it's the country or a geographical area. Is this considered standard of care? And there are a lot of things that we prior auth that become that. And in that case, then we take them off review and we will pay for those because they are the best treatment for that member at the time. So it's a continuous process. There's a whole bunch of people involved, including external subspecialty representatives, our provider services, our member management, because our member really is the focus of wanting to give the best, most appropriate care.
Thank you. That's very helpful.
So,
Sort of establishing the framework within which MVP works overall. Appreciate it. All right. Questions committee. All right. So we're going to move on to Kelly Lang, who is here.
Hello.
You've been sitting through it all.
I have, so Kelly Lang, I'm Vice President of Managed Care Contracting for the UVM Health Network. Really, that aids at the full title. It's now contracting for really our commercial government payers. All the interactions you've heard about here that my very talented team works with payers on. So thank you for having me. You've heard a lot. My testimony is should be on the website. So I'm going to hit on some kind of high points because this is the basis, as Jerry said, and there'll be further conversation, which I'm happy to engage in. I want to take a step back because there's been a lot of information thrown out and really level set an interpretation of why we're here. It's the burden of healthcare providers and patients and also payers that we're trying to really look to align. And alignment is a phrase I might overuse because that is the basis.
No, you can't overuse it.
Okay, then just.
I invented that.
Oh, well.
8 years ago.
Now I know where to footnote and give you credit. To use Andrew's example, which I get he was getting at, if you're at a restaurant and you have a menu, what providers, and I say providers, as you've heard from FQHCs, independents, hospitals, what we're now is that we're at a restaurant and we have a menu, but depending on the waiter you get, depends on what's available and how much you pay. And that's really what you have, is you don't have a menu where everyone's doing the same thing. So alignment, standardization is really the goal of this legislation and where the focus has been. So you heard MVP say step edits consistent with New York. There's a couple concerns and we've worked to compromise on those as it went through from the House to here. So for example, the 3 focus areas of the bill, I think step edits you've heard and kind of some consistency there. The claims edits, the pharmacy example that was given, we've removed, pharmacy, we're really focusing on, or excuse me, we've allowed for pharmacy claims in terms of having consistency among payers. We are looking to those national standards of care. A large national payer, over a third generally of panels, Medicaid, generally another third. And what we're now hit with is commercial payers that do vary within that final third, creating a lot of inconsistency for all providers, which adds to cost, which gets to what we've all talked about is the cost shift, the burden to commercials. If we're putting more administrative burden, that cost gets paid by those commercial payers who are causing that administrative burden. So it's cyclical, and what the bill is not focusing on the cost shift, which I think we've heard about here, and we understand that's a broader issue for many years. What we're trying to see is where we can create alignment to reduce the burdens and administrative costs on the provider side and commercial. And so on the claims edit side, what the focus is where we can have reasonable standards. And it's how they're applied is a lot of what that conversation has been. So Blue Cross, which I'm glad to hear they're pulling back the policy. We have not been notified of that. I still have staff that we've moved from regular analytics to sending emails today, which they would be very happy because they're pretty unhappy with their work quality right now. They're not happy. It's not the job they were hired to do. So removing these policies is important by how we get notice. Shouldn't be a committee. It should be communication with the providers. And that's where you see a lot of the bills and consistency when changes can be made, how they're made. If you align with Medicare, there could be some changes that DFR allows. Medicaid follows similar, what are the NCCI edits. And that would actually get to the bundling example. That's taken care of in this claims edit. The NCCI edits allows for that. Like Andrew, I was on that fair claims policy, so unfortunately I know a lot about this stuff that's been going on for years. And we can say it's been going on for years and it's okay. It's gotten worse with technology and the additional codes. And the thing is, we want to bill correctly. The post-claims audits that Dr. Lynn talked about, she passed 100%. We have high 70s% on these 259 25 modifier. I just pulled a subset. We're getting almost 80% passing, but one thing that I found, we're not even working the claims under $50 because we don't have the resource. And I know we heard providers in the House testifying they're not going after the money because it's too much work. And so they don't want to hire staff. So the purpose of this component and then the prior auth is really alignment, consistency, and transparency and how we can process. That will allow us to use technology and automation. So to the point of self-insured could have their own rules. Most of the time, self-insured follow the commercial payers from what we've seen on the provider side. And still, if we included on claims and prior auth alignment with Medicaid, we're over 50% of our claims. That allows us to automate. And that's one of the biggest things right now is we have to have manual work because even if we get a waiver, staff aren't sure. Are we sure that waiver is still in place because it's on a subset of a population? And so all these are in the weeds details. We can give lots of examples on, but the components here is what we're trying to get to is alignment, transparency, and consistency between the payers. And if we have Medicare and Medicaid doing very similar things, some good basis, and that's where we work to do. A couple specific points on just simply on the prior auth, just to give, there's, the focus has been really on the medical side, where we say the provider hospital. There are less, the cost shift being one component, prior auths should be for safety. There is a cost component as well. But if Medicare is allowing them and the patient safety is the concern, we would think a large payer that we all pay for in the state has PAs for a reason and looking at in appropriate cases and doesn't in other cases. Also, if an MRI doesn't have a PA in Medicaid, but again, they do in Blue Cross, we're seeing approval rates of the high 90%. So you may have a prior auth, but if you're getting approval, then why do you need it? So those are the things that are buried and simply not benefit to that patient care because now we're pulling nurses, doctors, and staff away from scheduling. You know, we cannot schedule someone because we have staff sending medical record emails one by one. We can use these resources better. And, you know, the final key point is the accountability and where we're talking about cost savings and the cost of this. Right now, there's a cost of this already in premiums. The healthcare administration on provider side is going into rates. It's what's happening if it's not being covered by Medicare and Medicaid. But the other part is the workforce cost. If we're having to retrain, hire, you've heard people leaving. And I want to focus on not only the provider, but the non-clinical staff. Those are really important components and equally as important to getting a claim processed and a patient scheduled. And if we're having them leave, then we have to train new people. It's all more workforce costs. And so that gets transitioned. So those are the biggest components we need, and, understanding the cost and accountability is something we put in and reporting back in this bill is if we're going to be able to cut an FTE and enrollment, or excuse me, getting a claim process, we could use that nurse elsewhere. It's a job we don't have to hire. We have people in our system we can redeploy and should. I've got an MBA graduate who's online right now is my genius in this helping. She's working these payment policies, reading 500 pages a week. She has a lot more talent we could be using in analytics and determining how we can better price and look at our processes. So again, are we maximizing the resources we have? And that's what I think, if we get to alignment, to use your word, but also transparency. I want to keep that you did that too. We want to be deliberate in this process. We want to bill accurately. It's inappropriate to have claims that are not processed or triple payments. And we want to know that. And I'll just say the final thing is we need to know that if we're moving to value-based care, global budgets, hospitals need to make sure we're not inaccurately billing, because that's then all our dollars we're doing services. Patient safety is first. But if we have waste, we're already looking at that. Are we capturing everything? There's still opportunity. There's new data and analytics tools. But we need to be responsible for that if that's where this world is moving. That's where we're responsible in Medicare already. We're limited in our funds and in Medicaid. So all things in process, all room for improvement, and that this bill is a step to get there. It's not meant to just throw away the system. We all agree PAs have a service, claims that it's may have a service, but let's have some consistency. So I've tried to go in 4 minutes and not speak too quickly. But those are the high level points, and again, happy to come back for any further details.
Thank you. And I think, we'll have to go through the bill again and look at what everyone has said and see what we can do. The alignment piece is pretty critical. We understand that. The savings are critical as well.
Thank you.
Thanks. All right. So committee, we've really had a lot of testimony on this. And I'm just gonna say, let's just leave it for now. We'll come back to this bill again. And there are things we need to hear more about. I understand that. So we'll try to do that. We also need to go through the bill in detail with Ledge Council so we can really drill down and understand what we've heard and how it fits. We did have on schedule today, representative to come in and testify, Eric McGuire from the Rutland Businesses. Yeah, yes, very good. That is on schedule. Did you send him a
I
note?
talked to him this morning. Said he had received,
Kiki would.
advice on it.
Yeah, she sent him an invite. Yeah. So is he available now, or do you want to, we can postpone that until, tomorrow or Friday if you want to. No, like keep it one place.
Actually, it's not on.
I have them right here.
Here, my, this was on here.
Special agenda. Yeah, so we'll put that on. Since he didn't know about it, we'll invite him to be on.
Saw him at 8 o'clock this morning.
Yeah, okay. Curious, we'll have to sort that one out. Thank you very much.
Thank
you. Good. We did have Pat Jones. Is she available to answer that question? No, the question was on the, drug importation. Oh, okay, well, I'll give it to you. All right, so we'll have a little time. This has been a lot. It's just very intense, and there's a huge amount there to understand from all perspectives. I just encourage you to read the testimony and look at the bill again, and we'll come back to it and try to sort out where everything fits. I did ask to switch topics. So, we did our prescription drug advisory board, with Green Mountain Care Board. And one of the bills that we had, that I referenced on the floor that we had passed, 2 years ago, 18, I think, or 19, was, bill on drug importation. And so we asked for a report back on the state importation program. So Vermont was required by the legislature to submit a state importation program before the FDA finalized their rules, so that FDA would consider it. The state may or may not have been considered because of our relative, I'm reading a message from AHS. Because of our size and relative buying power, it's most likely they will sense for us to partner with another state. So I don't know whether the administration is moving forward with that or not. But we did ask them to work closely with other states, and one of those states was Florida, which has completed its application and has received approval for importation from Canada. So AHS is encouraging NASHP, the National Academy for State Health Policy, to reconvene a state importation program working group, and they'll be reaching out. AHS will be reaching out to Colorado, which previously was open to engaging with Vermont on a partnership. And they'll continue to be in touch with the congressional delegation. So that's as far as we are with importing from Canada, even though we're, I don't know, how many minutes from the border? So, I will ask AHS to continue with this process. It's now in the administrative hands. Just wanted that update for you. It bothers me from time to time that we haven't had.
I was writing that to Jane.
Oh, no. Huh? So we're good.
You good for that?
Okay. That was bad move. All right. Thank you. That. Okay. So that's it for today, but we're gonna come back to 766. I think it's a really important bill to us and to our Vermonters to healthcare. One of the comments that I heard today from someone was that there's not enough money in the system to cover all the costs. And I've heard differently in the past. There's a lot of money in the system. We could just structure it. That's why we have global budgets going forward with hospitals.
Where's Greenville Care Board coming to this? Is it 8766? They don't, very well. They don't have,
We'll invite them. I've invited them to come in and testify. They don't regulate, all they do is approve. They approve insurance rates. They might recommend changes. DFR looks at insurance rates and does the actuarial analysis to ensure that insurance companies are solvent. And then the rate recommendation goes from DFR to the board, and the companies present and support their request.
what about people? What's it?
DVA is in charge of Medicaid. And have them, and
Yeah, I think it would be good to have
we're gonna have,
Fremont Care Board, DIVA and DFR.
have them all on this.
Yeah.
Okay. And each one has a different role within the bill, to a greater or very lesser extent. All right.
Thank you.